I am online. I'm ready. Please confirm that you can see here my slides.
Everything works fine.
So thank you for the introduction. The unanswered question is, who are the most suitable patients for mitral interventions, whether this is TEER, whether this is replacement, and what is the profile? So clearly we had some conflicting data in the previous decade. So COAPT and mitral FR, there was a divergence. New hypothesis came, proportionate MR versus disproportionate. Two conflicting results, highly positive outcome on COAPT, a neutral result on mitral FR. And there's little doubt that at 5 years, COAPT showed significant benefit in this endpoint, which is all heart failure hospitalization and mortality in this particular population of patients with reduced ejection fraction, severe MR. The practice was aligned with COAPT-like patients, and it still is. The mitral FR patients that were patients with bigger ventricle and less severe mitral regurgitation were considered as not suitable. However, Reshape HF2 as a tiebreaker maybe came to shed some additional light, and this was a Greek trial that 3 centers actually participated in putting 237 patients in total of 505 patients, and showed that even in patients with less severe mitral regurgitation with similar left ventricular dimensions to the COAPT patients, not as big ventricle as the mitral FR, but definitely less severe MR, showed significant benefit in terms of recurrent heart failure hospitalization, first heart failure hospitalization. And we did see significant improvement in patients' quality of life, 6-minute walk, NYHA class 2. And you can see what was the difference between the trials. Mitral FR had bigger LVs. COAPT had more severe mitral regurgitation. Reshape had less severe mitral regurgitation, but smaller LVs, and still patients derived benefit. And so this proportion versus disproportion mitral regurgitation theory is actually being challenged. But we definitely need more evidence, more data when it comes to moderate MR patients with reduced ejection fraction. And of course, we have a gap of evidence in the atrial FMR cohort, which is our preserved LV function patients with almost normal LVs in terms of dimensions. But definitely the guidelines, the European guidelines have aligned with this new evidence. So when it comes to primary MR patients that are anatomical suitable and of course are considered high risk for surgery, then 2A indication for TEER is there. When it comes to secondary MR, ventricular SMR, no concomitant coronary disease, the TEER is now recommended with class 1 level of evidence A. So I can actually go one step further and saying that if you do not consider a patient like that, a patient that is on GDMT optimal and had received a CRT, if that is an indication for this patient, then it may be considered as a malpractice not to implant the TEER device in these particular patients, because the prognostic benefit is huge and the symptomatic benefit. In the atrial SMR patients, of course, they may be considered as 2B. Surgery still has a role there, actually more upgraded in these guidelines, but more evidence is coming for TEER, which is actually quite effective. When it comes to anatomical selection, clearly we have an ideal versus a non-ideal patient, and the more features we have on the left, on the green area, the more suitable this patient is to have an optimal result. So a patient with a central MR jet with significant length that can be grasped, with some apical tethering, large orifice area, lack of calcium, not many cords in the grasping zone, clearly can benefit. Any patient that has a lot of these features like presence of calcium, thickened leaflets, Barlow's disease, shorter leaflets, more cords, prior surgery, the more of this you have, the less suitable the patient is. So the green light patients are these patients, mitral area more than 4, minimal calcification, adequate posterior leaflet, tending height less than 10, A2P2 pathology. And of course, these patients can be clipped with over 95% probability of achieving a +1 or less residual MR. This patient clearly is red light, small area, lots of MAC, almost non-existing posterior leaflet, then it's a no-go for this patient, unlikely to have a good result. And of course, you have these yellow light patients with multiple jets, especially when you have commissural areas and central areas. And of course, standing height, more width of flay leaflets, more, and mitral area with restricted annulus, less than 4, but more than 3.5. These are the sort of patients you can achieve excellent results. These are the sort of patients you need to put a TEER device. This is a patient that you can say it's a yellow, there's calcium, there's a short posterior leaflet, but you can achieve a good result putting a TEER device. This particular device is a Pascal device with no gradient and minimal. And this is an atrial SMR patient. I think more focus needs to go to this profile of the patient's horizontal leaflets, but good enough length. You can actually implant the TEER device. This is an XTW clip and have a good result. These are usually elderly female patients, maybe male patients with chronic AF, and these patients can be high surgical risk. I'm not sure if ablation can be meaningful in this particular patient with a huge LA. So TEER is a good alternative, and I think, in my humble opinion, the 2B is not good enough indication for this population. But you have patients like that. This is a patient that we actually enrolled into the Atlas TMVR trial for the Alta valve. You can see that the posterior leaflet is almost non-existent. And actually, the mitral regurgitation is located in the medial aspect of the valve, and it's severe, as you can see, with certain tilting of the probe. And in this particular area, there's a lot of calcium. The posterior leaflet is non-existent. So clearly, this is not a suitable TEER patient. Even if we grasp somewhere in the area reliably, we will not be able to reduce the MR. So this patient was implanted with a TMVR device. So as key clinical messages for the anatomically suitable patient, and we can discuss a lot about where would you put the bar towards the red zone patients. Clearly, the new evidence that came from the RESHAPE HF2 shows some light that the functional mitral regurgitation patients with big LVs, with ventricular dilatation, will benefit a lot from TEER. Clearly, this reinforces the fact that mitral regurgitation is a therapeutic target, not a bystander, and it broadens our treatment scope beyond the coap patient. And of course, heart team decision is mandatory. Thank you very much for your attention. I'm happy to take questions.
Thank you very much, Vlasi. It was a great presentation. I just wanted to ask you a question. How do you see a constellation of combined interventions? I mean, you had a really nice picture of these multiple jets when you practically think you need like a zip to zip the mitral valve in order to fix that, and you have maybe much more, a little more gradient. Would you consider like a solution like an annuloplasty with the Carillion device, so to maybe facilitate a more simple TEER in the second step? What's your opinion about that for this kind of MRs?
I mean, the landscape is changing a lot in that field, maybe not as rapidly as in the tricuspid valve that we saw in the previous session, but clearly there's a lot of evolution. We have TMVR devices coming in, M3 is commercially available. More devices are coming slowly into the market, hopefully in the next 2 to 3 years. So we have to revisit and reevaluate our toolbox for these interventions. Clearly, a combination device is very attractive, especially in the atrial population. I think getting an indirect annuloplasty with a Carillion device, which is a very simple, very efficient, and very quick, and it gives you options for the future, may give you a reduction in the anteroposterior diameter, and then for a huge valve with a horizontal leaflets and minimal coaptation, you may make your life easier in the next few months, and you can put less devices and have a more durable result. Clearly, this is not validated in trials, but it's a concept that may work.
One question. What about the concept of treating early with a TEER device in order to upgrade or make the medical therapy optimized?
That's an excellent question, Moni. I really think that we should not waste too long in optimizing medical therapy in these patients. And that of course depends on the practice that exists in different countries, different centers, but really wasting like 6 months to a year, and this is an arbitrary number, of course, by titrating or failing to titrate medication for an individual patient with heart failure may prove detrimental for the patient outcome. So it's not uncommon to see patients after 3 or 4 months of an attempt to optimize medical therapy to actually go downhill, decompensate, and then it's too late for them. So I think you should make an effort, like 1 month maybe. Most of these patients are restricted with their hemodynamic insufficiency, so they have low blood pressure. You cannot really optimize medical therapy. You put a clip, and then you find down the line that the patients get immediately better, and then you're able to put more therapies, like increase the dose of the RNAs and give less diuretics. And patients do derive a combined hybrid benefit from both approaches.
Thank you very much.
Thank you.
Thank you for your great presentation. Have a nice day.
So the next